Let's turn our attention to the treatment of sexual dysfunction. Traditionally, sexual dysfunction was treated with psychodynamic therapy, where the idea was to uncover the unconscious processes that were getting in the way of normal sexual behavior. It was a long process, very expensive, and generally ineffective. Now, the therapy may not have been worthless in the sense that it often helped the person to understand themselves better, but it was not effective in reducing the sexual dysfunction. In contrast, the modern approach is based on the work of Masters and Johnson, which involves a thorough understanding of both the physiological and the psychological elements of human sexual behavior. Some of it is simply education. It's amazing the number of sexual disorders that are just a matter of not understanding what works. For example, have too many drinks and it might relax you, but it is probably going to interfere with your sexual response. Teaching couples to exchange information, to tell people, their partners, what it is they like and what they don't like. Anxiety gets in the way of sexual functioning very easily, so learning to manage your anxiety is so important. And then there are specific techniques. We'll talk about several of them for particular disorders. If there's a medical condition, it needs to be diagnosed, and usually any kind of assessment in a modern sex therapy clinic will include a medical evaluation. So our focus from now on will be on modern treatment, which is typically done within specialty clinics where the people treat almost exclusively sexual problems. Sexual touching is a part of most desire or arousal disorders. It's called sensate focus. The key element there is for the partners, and by the way, within sex clinics, they always work with couples. The partners are given homework assignments to touch one another and to communicate how that touch feels so that they can find out what's going on. The key element to sensate focus is that they are forbidden from having sexual intercourse. What that does is it takes the pressure off. Often the pressure increases the anxiety, which leads to sexual dysfunction. So taking the pressure off allows them to enjoy the pleasure and to learn something about their partner. Outside stimuli, basically softcore porn, is often effective in exchanging information with your partner and learning what excites them. Communication could not be more important. Often, couples assume that if you love one another, you automatically know what it is they would like and what they would not like. But that's nonsense. There's no way of knowing what they would like or not like if you don't exchange information. For those individuals whose lack of desire is a result of trauma, you have to use the kind of treatment that you use for PTSD to deal with the trauma first and then use the techniques that we're talking about here. Again, if there are marital problems, it's very hard to make love to someone you don't love. And so typically a sex clinic will say, I think you need to do marital therapy first, and then if the relationship is strong after the therapy, we can look at the sexual dysfunction. Hormonal problems on rare occasions contribute. They're easy to diagnose, they're easy to treat. Usually you take a look at it, but rarely is it the focus of the treatment for desire or arousal disorders. Everyone knows about erectile dysfunction because, well, there are commercials constantly on the television, on radio, on the internet. And the reason is very simple. These are enormously profitable drugs. Often the people pay for them out of their own pocket because many insurance programs do not cover them. But since one's sex life is so important, paying $10 for a pill is usually not something anyone would think twice about. You're probably familiar with many of the brands. Viagra was the original pill, but Levitra and Cialis are both available. There are cognitive behavioral approaches that also help with erectile dysfunction. They're often combined with the medication. There are ways, even more powerful than the pills I've just mentioned, to increase the likelihood of an erection and maintaining that erection. There are vasodilating drugs, but the problem is they have to be injected. And they have to be injected directly into the penis. There aren't a lot of guys who want to put a needle into their penis. In fact, generally, these drugs are injected on both sides of the penis, so it's 2 shots to the penis. And frankly, there aren't a lot of partners of guys who want to do that as well. But it works, and it's been around for a long time. Sometimes the erectile problem is a result of some more severe problems, such as a spinal cord injury, in which case the only way to get an erection is to surgically implant a device that makes the penis erect. Sometimes you use devices that can be pumped up so that the penis is not erect all the time, but only erect when you want to have sexual intercourse. The treatment for premature ejaculation involves training the male to have better control over their orgasm. Now, as I mentioned before, this is a problem in younger men, and typically in 2 or 3 years, the problem would disappear all by itself. One technique is called the squeeze technique. It involves masturbation, either by the person themselves or with a partner. And just before you reach the point where an orgasm is inevitable, the partner or the person squeezes the base of the technique very tightly. What that does is it decreases the arousal and sometimes makes the erection soft. And then you repeat the technique over and over again. Another approach does not use the squeeze technique, but essentially does the same thing without the squeeze technique. It's called the stop-start technique. I've seen textbooks who call it the tease technique, because what you do is you arouse the male to the point where they're almost ready to have an orgasm, and then you stop. And the male then allows themselves to reduce the urge for an orgasm, and you repeat that technique. Again, in both cases, what you're trying to do is you're trying to get the male to learn how to control the response so that it's not so much on a hair trigger. Orgasmic dysfunction, where you're not having an orgasm, is typically done with guided masturbation. Remember, releasing for an orgasm is a very important element of sexual response. The longer you can hold back, the more intense the orgasm. But if you're holding back too much, you may be at the point where you can't release. So what you do is you use masturbation, because with masturbation you have absolute control. You know exactly what's happening. Once you learn to be able to control your arousal to the point of orgasm from masturbation, you then have your partner involved in the masturbation. So you have mutual masturbation. That requires a little more communication, but it can be done. And then the third step is intercourse. Again, you're learning to control the sexual response through practice. We have 2 pain disorders, and they're treated very differently. With vaginismus, what you have is a reflexive response. As I mentioned, it's like having a Charlie horse of the vagina. And it becomes an automatic response. Any kind of penetration could be sexual, but could be as simple as inserting a tampon is sufficient to trigger that response. What you need to do is teach the person how to relax those muscles, because that reduces the likelihood of this reflex, and then gradually expose them through penetration to larger and larger objects until the penetration no longer triggers the reflex. It's a fairly effective technique, but it takes a while, and it takes a lot of patience for both the patient and for their partner. With the pain disorder, usually what you have is scar tissue that's causing the pain. So what you need to do is you need to not stimulate that scar tissue. The way it's usually treated is a doctor who's a specialist will do a thorough examination, identify exactly where the scar tissue is or the intensely sensitive tissue, and then suggest to the individual positions that will be sexually satisfying but will not stimulate that part of their anatomy. In most cases, after the exam, it's 1 or 2 sessions with the couple, suggesting positions that they can try, and then having the couple come in and say, okay, these worked and these didn't. And with just a little bit of adjustment, typically they can find positions that will be satisfying for both people and not painful. Although we've talked about the main sexual dysfunctions, there are other sexual dysfunctions. A good number of them are secondary to physical disorders or to medications you might be taking. Sexual dysfunction is a very common side effect of many medications. So if a person is experiencing sexual dysfunction, probably a good place to start is with the doctors who prescribe medication and ask them if there's any possibility that that could be resulting in the sexual dysfunction that you're experiencing. There are also some other sexual dysfunctions that are less common. We're not going to cover them in this chapter, however. The second class of sexual disorders covered in this chapter are called paraphilic disorders or paraphilias. These used to be called abnormal sexual behaviors. In sexual dysfunction, the person is unable to do something that is considered normal. In paraphilic or abnormal sexual behaviors, we're talking about individuals wishing to engage in things that are considered, at least by some people, to be abnormal. Paraphilias are defined as intense sexual urges and fantasies, which often lead to behaviors that involve objects or non-consenting individuals, or sometimes physical pain and humiliation. In other words, the person gets turned on by things that typically don't turn other people on. Now, the diagnosis technically requires that there be some distress on the part of the individual. And in fact, that tends to be used in some situations, but not others. I'll emphasize that as I'm going through. Let's start out with fetishism. A fetish is excitement over a specific object, such as women's underwear, shoes, boots, etc. It affects about 11% of males, but about 6% of females, so females experience this as well. If you're wondering what this photo is, it's a small piece of a high school gymnasium that is covered with panties and bras that were stolen by the panty bandit who went to jail. Now, if someone wants to wear women's underwear and they buy the underwear from Amazon or some other online store or goes to one of the stores in the mall and buy it, no one would care. The panty bandit went to jail not because he wanted to wear panties. He went to jail because he stole these panties. And he stole them from the dressers of women while they were sleeping, often 2 or 3 feet away. If you've ever had your house broken into, you know how unsafe you feel after that. And he did it to hundreds of people over a long period of time. That gives you an idea of how powerful these feelings can be, that he would take such huge risks and continue to take it when basically the entire police department was looking for him. Often confused with fetishism is transvestic fetishism. Here it isn't just the excitement of having the clothing, but of wearing the clothing. Now, this photo here is from the Rocky Horror Picture Show, and in some ways it's not a very good example of typical transvestic fetishism. There are men who will openly dress as women, but most people who engage in transvestic fetishism are heterosexual. They're often married and they hide this from their partner. And typically, they go out of their way to make sure no one knows about it. So they would never dress up and go out in public. Of course, you've all heard of exhibitionism, the flasher. By the way, the photo here shows the fellow flashing a statue. That wouldn't be very effective for someone who's an exhibitionist, because it isn't showing your genitalia that is the exciting part of it for them. It's showing it to an unwilling partner. So being a stripper, for example, might be thought of as the perfect job for an exhibitionist. But the people who go to strip clubs want to see you naked. They're not going to be shocked by that. The same is true of voyeurism. You'd think the perfect place for a voyeur would be a strip club, because they could see naked people as much as they wanted for the price of admission. But in fact, that usually does not excite them any more than it would excite another person. What excites them is viewing people who are naked or nearly naked in situations where those people don't realize they're being observed and would not want to be observed. So often people who are voyeurs, when they do get caught, they get caught trying to peep into people's windows rather than paying admissions to go to a strip club. Now, many of the paraphilias that we've talked about are things that you probably have heard of. This one is not. It's called Voyeurism. Voyeurism is physically touching people in a sexual manner who do not want to be touched. Now, if you do that in a variety of situations, you may very well get arrested. You certainly wouldn't do it at work. You might very well get fired for that. So typically this occurs in very crowded situations where the person is bumping up against other people and would barely notice that they're being touched because, well, there's touch all over the place. So a crowded subway, a crowded elevator is where this is likely to occur. What's particularly interesting about this this paraphilia, is it tends to be young males and only young males. It's very rare to see Voyeurism in a male past the age of 25. So there's a brief period of time when this may occur and typically does not occur after that time.